Welcome to the debate. Imagine a 12-year-old girl being treated for just a simple iron deficiency for 2 entire years.
Okay, 2 years is a long time.
It really is, and her care is entirely managed by algorithmic symptom checkers and protocol-driven staff. They routinely check her blood, they note the low hemoglobin, and they prescribe more iron.
Right, following the standard pathway.
Exactly. But it wasn't until a doctor finally evaluated her for acute abdominal pain and performed a fundamental physical examination by actually touching her abdomen that they found the real culprit. It was a massive failing kidney.
Oh, wow. Yeah, that's a catastrophic miss.
Right. And today we are exploring this really murky, high-stakes shift happening in modern healthcare system design. We're moving away from traditional, experienced physician-led clinical examinations and shifting heavily toward protocol-driven care, algorithmic triage, and, task shifting to nursing staff and non-clinical personnel.
Which, to be fair, is a profound structural paradigm shift. I mean, it completely redefines how we manage population health on a massive scale.
And it raises a critical tension. So the central question we're exploring today is this. Does delegating diagnostic tasks to rigid protocols and non-physician staff compromise patient safety by removing the essential clinical eye?
Or is task shifting an effective, highly evidence-based strategy that actually delivers equal or maybe even better health outcomes?
I represent the perspective that the absolute foundation of medical care is the clinical eye. Abandoning the rigorous physical clinical examination for tick box checklists inevitably leads to catastrophic misdiagnoses.
And I represent the view that systemic health design has to rely on population-level evidence, not just anecdotal failures. Task shifting and clear protocols, when they're applied correctly, are proven to manage defined conditions highly effectively. I mean, the rigid demarcation between doctors and nurses is just an outdated model.
Well, let me begin by defining what we mean by the clinical eye, because it's not some mystical aura or sixth sense.
Good, because we can't base health policy on a sixth sense.
Right, exactly. It is the comprehensive, synthesized application of deep pathophysiological knowledge combined with a rigorous physical examination. It's touching the patient, it's listening to their breathing, observing their gait, looking for incongruities that a piece of paper simply can't prompt.
But a system serving millions of people can't rely on individual artisanship, can it?
It has to rely on expertise. When we replace this with rigid protocols run by non-physician staff like nurses or chemists who haven't gone through a decade of intensive diagnostic medical training, we basically commit negligence through omission. We miss the disease because the algorithm didn't explicitly ask us to look for it.
I see what you're saying, but I come at it from a different angle. Healthcare is no longer an artisanal craft where a single physician operates as a lone genius. It's an immensely complex system. I'm not arguing for lone geniuses. I'm arguing for baseline clinical competence.
Sure, but systemic health design relies on evidence. If you look at the findings of the expert panel on health system design, the data is incredibly clear. When allied health professionals take on defined tasks like chronic disease management or routine prescribing, they achieve outcomes that are at least as good and sometimes demonstrably better than doctors.
Better? By what metric exactly?
By the metric of reducing unwanted variance. Let me offer an analogy from aviation. We don't let commercial pilots fly jets based purely on their clinical eye of the horizon, right?
Well, airplanes aren't biological organisms.
No, but human error is a universal constant. We force pilots to use standardized checklists because human ego, cognitive bias, and fatigue are statistically far deadlier than a rigid protocol. Algorithms ensure that the standard of care is applied universally.
I see why you think that. But let me give you a different perspective grounded in the biological reality of human suffering. Let's go back to that first case, the 12-year-old girl with the failing kidney.
Right.
How does a system miss massive renal failure for 2 years? By relying on a protocol that treats isolated lab results without ever performing a physical examination. The staff just kept checking the box and prescribing iron. The fundamental failure here was treating the dashboard instead of the engine.
That case is deeply unfortunate, I completely agree. But I'm not convinced by that line of reasoning because it misidentifies the root cause.
How so?
The protocol was the root cause.
No, what you are describing is a failure of protocol engineering, specifically a failure to escalate. Appropriate protocol-driven care relies on explicit cutoff points.
But what good is a cutoff point if the protocol is looking at the wrong metric entirely?
A properly designed cutoff point looks at treatment efficacy. If a patient is on iron tablets for, say, 3 months, and their hemoglobin doesn't improve to a specific quantitative threshold, the protocol itself should hard lock. It should dictate a mandatory referral to a physician.
But you're assuming the symptom presented is a simple single condition to be managed. You don't actually know if a condition is simple until you've thoroughly examined the patient to rule out the complex. For single condition management, though, protocols do excel. Having nurses manage this frees up the highly trained doctors to handle the complex, multi-system cases.
Okay, but let me give you a second case that shows why that doesn't work. A young woman presented to a clinic with complaints of excessive hair growth. She was seen by a non-physician professional who conducted an examination with the patient's clothes completely on.
Well, obviously, an endocrinological assessment requires a proper visual inspection.
Exactly. But because the protocol was designed as a superficial checklist focused just on her self-reported complaint, the fundamental diagnostic process was abandoned. They completely missed a glaring case of hirsutism.
Which is excessive hair on the body.
Right. Excessive hair on the legs, cheeks, and chest. And this isn't just a cosmetic issue. It's heavily linked to severe endocrine disorders like polycystic ovary syndrome or even adrenal tumors. An experienced doctor knows you cannot visually assess a hormonal condition through fabric. The protocol failed because the system structurally didn't require the staff to look beyond the immediate complaint.
That is a compelling point about physical examination. But have you considered that the clinical eye of a physician is also highly subjective? Have experienced doctors never misdiagnosed an endocrine disorder?
Of course they have, but
Have they never skipped a crucial step in a physical exam because they were running 45 minutes behind schedule in a busy clinic? The argument for protocols isn't that they are flawless. It's that they provide a standardized safety net that works for population health.
I will gladly acknowledge that doctors are fallible. But a doctor's fallibility is a lapse in the application of deep knowledge. A symptom checker's fallibility is structurally designed into the system. It literally doesn't know what it doesn't know.
I think that's a bit reductive.
Well, take non-clinical triage systems, specifically the use of MAIA cards, the red, yellow, and green symptom codes used by receptionists and triage nurses. Here's a third case. A 20-year-old man walked into a clinic with a neck rash. A non-clinical triage protocol categorized it as shingles.
Okay, a common viral presentation.
Right, but he returned later saying he felt profoundly unwell. The receptionist used the MAIA card, found his symptoms finally matched the red code, and rushed him to a doctor. The doctor instantly diagnosed septic shock.
Right, but notice the mechanics of what happened in your own example. The MAIA card triggered a red code. The system escalated the patient to the doctor when the physiological parameters breached the safety threshold. That's exactly how an integrated system is supposed to work.
It escalated him when he was already in septic shock. That is not a safety net. That's a reactive scramble.
But primary care operates on statistical probability.
The initial assessment categorized him as having a viral nerve rash because the person doing the triage lacked clinical intuition. The true cause was a Staphylococcus impetigo infection. A protocol cannot clinically differentiate between a localized viral nerve rash and a highly aggressive bacterial skin infection just by asking multiple choice questions.
I understand the gravity of that delay. But again, triage algorithms are Bayesian systems. In a primary care setting, a neck rash is overwhelmingly more likely to be a viral presentation.
But efficiency is irrelevant when the treatment offered actively harms the patient due to a lack of pathophysiological understanding. Let's look at what happens when treatments are administered based on algorithmic probability. Case number 4, we can call it the Bonjela error.
The teething gel?
Exactly. A dying patient on chemotherapy and steroids presented to a clinic with a severe sore throat. The attending nurse, following a basic symptom protocol for sore throats, prescribed Bonjela.
Which is a localized treatment for a localized symptom.
Yes, but what the nurse fundamentally failed to understand was the underlying pathophysiology. The patient was actually experiencing disseminated intravascular coagulation, or DIC.
Wow. I mean, that is an incredibly complex cascade failure of the blood clotting mechanism.
It's a lethal hematological crisis. The coagulation cascades are inappropriately and massively activated throughout the body. It leads to systemic internal bleeding and organ failure. And the nurse actually reassured the family that the patient's blood tests were normal.
Because she didn't recognize the context of the oncology treatment.
She didn't understand what DIC was, nor did she understand how the patient's chemotherapy and high-dose steroids actively suppressed and masked the typical inflammatory responses you'd see in blood work.
I'm sorry, but I just don't buy that this invalidates task shifting as a concept. Let me tell you why. Disseminated intravascular coagulation in an oncology patient is at the absolute extreme edge of medical complexity. It's an outlier.
An outlier that killed someone.
Yes, a tragedy, truly. But algorithms and nurse-led protocols are built for the center of the bell curve. If a healthcare system mandated that every single patient with a sore throat had to be evaluated by an oncologist to rule out DIC, the entire system would collapse overnight.
I'm not suggesting every sore throat needs an oncologist. I'm saying the system forced a phenomenon called diagnostic anchoring.
Define how you are using diagnostic anchoring in this context.
Diagnostic anchoring occurs when a protocol latches onto a common complaint, like a sore throat or a rash, and stubbornly refuses to see the highly serious condition hiding directly behind it. The checklist creates blinders. Let me give you case number 5 to show how this anchoring causes immense systemic damage.
Go ahead.
An entire family breaks out in severe, intensely itchy rashes. Unqualified staff using a protocol diagnose them all with eczema and prescribe high-dose topical steroid creams.
Look, dermatology is notoriously difficult. GPs misdiagnose rashes all the time and refer them out to specialists.
But look at the mechanics of the error. Why did the algorithm default to eczema? Because statistically, eczema is common. But what did the algorithm fail to synthesize? The household transmission dynamics.
Because eczema isn't contagious.
Exactly. An experienced doctor looks at a family where the mother, the father, and the children all simultaneously develop a severe rash and immediately recognizes that it's highly infectious.
So what was the actual pathology?
The family actually had scabies complicated by secondary fungal infections. Now, consider the treatment offered. Immunosuppressive steroids. This is exactly the treatment I would never have given.
Because steroids suppress the local immune response.
Right. By applying high-dose steroids, they actively suppress the family's skin immune response. This caused the scabies mites to proliferate and spread rapidly and aggressively. The protocol didn't just fail to cure them, it actively weaponized the disease.
Okay, that highlights a gap in training regarding infectious differentiation, certainly. But the solution to the eczema and scabies case isn't to ban allied health professionals from evaluating skin conditions.
Then what is the solution?
Redesigning the protocol. If a protocol clearly states if multiple household members present with simultaneous dermatological symptoms, escalate to a physician, the system works.
You are placing an immense amount of faith in the ability of a static piece of paper to capture the infinite variations of human disease. Let me give you case number 6. A 12-year-old girl presented to a clinic with fresh blood in her underwear. She was seen by a nurse and, adhering strictly to a protocol, was treated for a urinary tract infection. No physical examination was performed.
Let me guess, the urine culture came back negative?
Completely normal. Yet the antibiotic treatment continued because the algorithm anchored onto blood in urine equating to a UTI in young females. What the protocol tragically missed, because it didn't mandate a physical examination, was that she was suffering from traumatic injury due to sexual abuse.
That is deeply sobering.
A doctor, utilizing the clinical eye, would have recognized the incongruities, examined her immediately, and triggered safeguarding protocols. Instead, the checklist provided a false sense of security and left a child in active danger. And look, it creates profound blind spots everywhere. I mean, I can rapid fire 4 more cases right now that perfectly illustrate this anchoring.
I'm listening.
Case 7. A pregnant patient whose severe abdominal pain and vomiting was completely dismissed as just gastritis by a triage nurse.
Well, gastritis and morning sickness are common in pregnancy.
Right. But anchoring on that commonality missed a critical acute abdomen. Or case 8, another patient presenting with vomiting and profound tiredness, and the unqualified staff falsely accused them of paracetamol abuse, completely missing the actual metabolic crisis.
Those are individual diagnostic errors, though. They happen across all levels of medicine.
Are they just individual errors? What about case 9, simple moles being misdiagnosed as meningitis by non-clinical staff using a flowchart? Or case 10, a child with HSP Hennig-Schönlein purpura also misdiagnosed as meningitis by staff just following a generic rash algorithm. The trauma of inflicting these wildly incorrect diagnoses on families violates the core principle of do no harm.
Anyone working in health system design must look at those outcomes and critically analyze how the system failed its patients. I grant you that. But my core argument remains. The failure was a lack of integrated oversight, not the concept of task shifting itself.
How can you separate the two?
Because you keep framing this as if non-physician staff are practicing in a void. A specialized nurse practitioner managing diabetes is incredibly qualified within their scope. A pharmacist managing routine hypertension understands the pharmacology intimately.
I'm not arguing that allied health professionals lack skills in their defined areas. I am arguing that patients do not arrive neatly categorized into those defined areas. Human anatomy doesn't adhere to the boundaries of a protocol's scope of practice.
That is exactly why I frame it differently. The clinical eye is a beautiful, essential component of medicine. No one in health system design wants to abolish the physician.
It feels like it sometimes.
What we want is to maximize the physician's impact. If a highly trained doctor is spending 4 hours a day managing routine prescription refills for stable asthmatics, they simply do not have the cognitive energy to catch the disseminated intravascular coagulation in the oncology patient. Task shifting clears the operational noise from the doctor's schedule.
I appreciate that vision. I really do. But the reality on the ground does not match that utopian design. You argue that algorithms provide a baseline of safety, but waiting for a protocol to fail, waiting for this safety threshold to be breached, means the patient has to suffer the wrong treatment long enough to trigger the escalation.
That's a risk inherent in any stepped care model.
In the case of the 12-year-old with the failing kidney, waiting for the protocol to trigger an escalation took 2 years. In the case of the impetigo turning into septic shock, the time frame was measured in hours, and the system almost didn't catch it in time. But the complex reality of human anatomy cannot be reduced to a statistical probability. Symptoms don't present in isolation. The experienced clinical eye remains an irreplaceable safeguard against catastrophic misdiagnosis because it synthesizes physiological context in a way no algorithm currently can.
And my summary is that while clinical vigilance is absolutely necessary, we must face the operational reality of modern population health. We have an aging population with surging rates of chronic disease.
Right.
Relying solely on the lone physician model simply cannot scale to meet that demand. Evidence shows that appropriately scoped, protocol-driven care is a highly effective necessity. It provides consistency that relies on systemic data, mitigating the inherent risks of relying entirely on the subjective intuition of whichever doctor happens to be on shift.
Well, it seems we agree, at least theoretically, on one functional necessity. If diagnostic tools and task-shifting protocols are to be used at all, they must be engineered with rigorous, fail-safe cutoff points.
Absolutely, we converge there. The moment a standard treatment fails to yield expected results, or a physiological symptom falls outside a strictly defined parameter, the protocol must hard lock.
Yes.
It has to immediately trigger a comprehensive physical examination by an experienced physician. The system must know precisely when to hand the reins back to human expertise.
But whether those cutoff points can ever truly capture the messy, unpredictable biological reality of a patient sitting in a clinic remains a profound point of tension.
It does.
We leave our listeners to reflect on that delicate balance between the efficiency of algorithmic system design and the irreplaceable depth of clinical intuition. Because at the end of the day, when you step into that diagnostic landscape, the waters are murky. We have to decide if we want an algorithm telling us how deep the water is on average, or an experienced guide who knows how to spot the drop-off right in front of us.
A vital question for the future of medicine, for sure.
Thank you for joining us.